Okay, so today what I'm going to talk about is neurological examination. So it is probably one of the most complicated, examination headings that you might come across. But I feel like I could take, into explaining this so that it looks a little bit easy. So there are numerous components, and usually in a medical examination, you're expected to follow an order. So first one is inspection. So these are just I'm just going to tell the order. So inspection, tone, power, reflex, coordination, and sensation. So this is pretty much the order by which you are expected to go with in an examination scenario. So now, sometimes in the inspection itself, like generally in the inspection itself, you might think like the gait of the patient should be coming over here, but that is where you're wrong. So when you're also doing the examination, the examiners tend to look at how comfortable your examination is to the patient. So in that instance, doing the gait at the end of the examination would be much more convenient for the patient because you wouldn't have to have the patient moving a lot here and forth uh, in a very chaotic manner. So you can leave gait for the last, but understand that you would be doing something similar to an inspection in that particular aspect. So now come to inspection. So what are you going to see in an inspection of a neurological examination? So it's pretty straightforward. It's basically what you can see. So you will be looking for any kind of scars, fasciculations, then atrophy. So these are basically one of the few things you'll be looking at. In addition to that, you will be looking at the gait. For easiness, I'm just going to include the gait here as well. So what are the different types of gait one might be talking about? So to understand that, we might have to first have an idea of what a normal gait is. So normal gait is, so when you tell a patient to walk through, you see some movements, right? Certain steps in the walking phase that they go through. So initially something like so what happens is, first, if you're looking at a natural walking stance, first the heel strikes. So when you're taking and you're putting down a leg, your heel strikes, then the toe becomes flattened, right? When your heel strikes, then your flat foot comes down and you have a flat foot. Then you have something like a loading phase. So you're loading into this leg, your weight is being loaded, and then what happens? Your heel goes off, and then your toe pushes the leg up. So this is pretty much your, what did you say, it's like a loading phase. Then after that, now you have a swing phase. So it could be the early, mid, and terminal swing, right? So that's basically what the normal gait would look like. Now let's say you are going through this normal gait. Now, what could be looking? What are the different examples of gait in contrast to this? So one common one is the antalgic gait. So antalgic gait is not exactly a specific, like one specific point. So it's like multiple joints. You see that the patient is having a limp, a difficulty in walking. Now, this can be secondary to osteoarthritis or multiple joint cause. So that is antalgic gait. So another one is ataxic gait. So this is what you sometimes see in cerebral palsy. So the patient is, somewhat, very unstable. So you have a wide base, a broad base. So they try to maintain the stability with a broad base. So that instability is something what you call an ataxic gait, and a commonest cause is cerebral ataxia. Then let's say Parkinsonian gait. So I'm just recalling one by one. So Parkinsonian gait, where you have the Parkinsonian disease, so they have this very rigid. They take the small steps. They have the shuffling steps. That is the rigid stoop posture and shuffling gait. Shuffling, they'll be shuffling their feet. So this is a Parkinsonian gait, a typical Parkinsonian gait. Then come to what can I say? What's the next one? Trendelenburg gait. Now this is weakness of the gluteus medius muscle. So you will see that one hip is a little bit lying lower than the opposite side. This is because the opposite gluteus medius is not raising the hip on the opposite side. because that's a function of the gluteus medius, is to raise the hip on the opposite side. So because of that lack of it not doing that, so you see a Trendelman gait. What Now sometimes the patient can also have some kind of a nerve being affected, so a foot drop, secondary to peroneal nerve injury, right? So now because of this injury, the foot drops. So now in order to make the normal movement, they have to raise their foot up. So this is a high steppage gait. So we've gone through several ones, and then another one would be so in cerebral palsy, you can have something known as spastic gait. So these are just some examples of gait that you can keep in mind when you're going through the neurological examination. Right. So now we have finished the inspection and also included the gait in it as well. So come to the tone. So tone is where you are evaluating the extremes of the limbs. So you are just making some movements to assess. So what are you trying to assess? Whether the limbs are joints movements are rigid or they are flaccid. Yeah, that's what you're trying to assess. They could also be spastic. So each of them are derivative for a lesion. So if it is somewhat spastic, it's an upper motor neuron. Flaccid is a lower motor neuron. And sometimes rigid or cogwheel rigidity is something that you typically see in Parkinson's disease. So that helps you identify certain things. Then come to the power. So for the power, we use something known as an MRC criteria. I believe it's the medical research criteria. So which evaluates the power of the muscles from a range 0 to 5, with 0 being no power and 5 being complete normal movement. So the values in between give a grading for the functionality of the muscles. So now look at, for an example, so one. So 0 is, I told you, there's no power, so no movement. So 1 is flicker. 2 will be movement without gravity. So how does movement without gravity, how is it assessed? So the person is not able to lift the leg, but there's some movement, so you remove gravity. So how do you do that? Is you tell the patient to move the leg horizontally, right? Not up but horizontally, and there you see. So if that movement is possible, then that is a 2. If it is slightly above with gravity, against gravity, it's 3. Now it fit completely, like they're able to lift it, but you see that there's they can't do against resistance, then that is 4. If they can do against resistance, then it is 5. So the different degrees, right? So like I said, it's no power, flicker, then again remove gravity, so not with gravity, against gravity. So a little bit reduced power, they can move but reduce power. 5 is completely normal. Now when you're doing the power examination, you can also assess the power at different moments, right? So a lot of the muscles have their own root values, and you might be able to check those things as you're doing the power assessment. So when you say, do I have assessed this muscle, they expect you to tell what is the power level that you are seeing at that particular point. So this assessment, they can be for the upper limb as well as for the lower limb. And the upper limb means, in the sense, we could be evaluating from the myotomy from C1 to T1, and then if you're going for the lower limb, we can go from L1 to S4. So this gives you an idea of how to check different root values even with the muscles itself. Right. So now for an example, let's say we are going to assess C1. And for just for your information, there's no way you can specifically check for the neck muscles. Like you don't usually check for the cervical one to what do you say, 1 to 4 in like a single manner, because there's a lot of muscles, neck muscles. So you sometimes have to check neck flexion. So for an example, C1, I can say I'm checking neck flexion. An example of the muscles that I'm evaluating is longus capitis. That's one way to just say it. C2, I can say sternocleidomastoid. What do you say? I'm checking C2 to C3. I'm checking neck movements. C1, C2, even you can say neck flexion. So C2, C3, you can checking neck movements. C2, sternocleidomastoid. Then C3, I'm again seeing neck for neck movements, shoulder elevation. So there is trapezius, right? Again, you don't want to say specifically because trapezius receives innervation from the cranial, the accessory nerve. So you and also some contractile cervical fibers. Then C3, 4, 5, innervates the diaphragm. So that's one way. But if you want to go with some kind of a root value, you can say C5 is deltoid, right? C3, C4, maybe you can say trapezius or something like that. But C3, C4, 5 is basically diaphragm. So that is there. Now, so deltoid is C5, C6 is biceps. So you can check those muscles, C6 is biceps, it's flexion. C7 is triceps. C8 is usually the finger movements, so flexor digitorum profundus. So C8 you can do that. Then T1 is basically the hand movements, the intrinsic muscles of the hand. So now from C1 to T1, right? So T2 to T12, that's basically the abdominal reflex. So you might not need that. So then come to L1. So again, now you know what we're doing. We are checking the power, right? So L1, L2, you can check that together. So that's basically iliopsoas, right, which is hip flexion. Then L3, L4 is the quadriceps, so that is knee extension. L4, if you're looking specifically, extensor digitorum longus is something you can check. L5 is basically extensor hallucis longus. Then S1 would be gastrocnemius solis, the Achilles. Then S2 would be your hamstrings. S3, 4, you can just assume the bladder and bowel control, spinsters. You don't usually, specifically let alone assess them, but you can think about digital rectal examination. So now you have an idea, like a complete idea. I think I've matched a great lot of the root values and muscles. So you have a complete idea now, right? So this is a very nice way to keep things in mind. So now come to the reflexes. I mean, you can basically derive the reflexes from these root values. So you don't really need to do much, right? So if you take for example the biceps, I told you it's like what, C6, but C5, C6 is basically your biceps. C7 is your triceps reflex. L3, L4 is your knee jerk reflex. S1 is your Achilles, this one. So there itself, from the reflexes is basically derived from, if you know the motor values, you can easily derive the reflexes. So we are going through inspection, tone, power, reflex, and coordination. Coordination again is something that it's interesting to check. So you just want to see there's a finger nose, like an individual will be holding the finger in front of you. So you'll be trying to touch from the tip of your nose to the finger, and you'll be doing from different regions. And then another example would also be the heel. You take the heel of your foot and try to rub it on the shin of the other foot. So these are ways you can check the coordination of the patient. Right. Sensation basically it's your you can check different things, and most of the time you're checking different things for a particular reason, because proprioception and vibration transferred by the dorsal column, pain and temperature transferred by the anterior and lateral spinal tract. So by keeping that in mind, these four things are you checking. You can keep that assess them based on dermatome levels. So just look up diagrams on dermatome levels. So they're not that hard to keep up, right? Just if you know this bacteria is the C4, and coming outside inward will be 5, 6, 7, 8, and T1 if you're looking for the hand, right? And if it's the leg, basically if you're looking from anteriorly, if you count all the way down, L1, 2, 3, then 4 will be on the inside, 5 outside, S1 outside. So it's a very nice, easy way to just keep things in mind. So yeah, so now we have finished the examination. Just a quick recap, right? So now this is just examination, but you need to have some clinical significance when it comes to the examination, just to keep in mind what you're dealing with. Now there are a lot of things, a lot of ways you can interpret this, but there are just a few things. Just I feel like you should know what you're looking at. Right. So one thing I feel like I left out was the Babinski. So it's one of the plantar reflexes that you will be checking, and it's very important to have that. So if you're going to do some of the interpretations, so Babinski is when you are assessing the plantar reflex, right? So you take some kind of an object, so maybe the tip of the knee hammer, somewhat a little bit pointy, not too pointy, or maybe even a key is enough. So you go around the lateral aspect of the plantar aspect, and you make an inward curve when you're coming towards the toe. Normal plantar reflex would be a downward movement, but in an abnormal movement, it will go upwards. So especially you have to focus on the big toe when you're looking at this Babinski reflex or the plantar reflex. So the big toe goes up means it's something abnormal, right? So that's an up motor sign. But however, you cannot do this in young individuals because young individuals in the sense very neonates, 1 2 years infants. Because the reason is that the pathways are not that mature, so you can't really elicit the proper response. Now come towards the interpretation. Let's get to the interpretation. So if there is if the um, tone, power, and the reflexes are increased, then it's an upper motor neuron. The opposite, if it's decreased, the tone is decreased, power is decreased, and the reflexes are decreased, it's a low motor neuron. In addition to this, if you're seeing the Babinski, which is the plantar reflex, you're seeing that reflex, then it's also an indication for upper motor neuron. So that's one. So now let's think if it's a spinal cord, if not just spinal cord, cerebellar region. So you will see some coordination issues. You will see ataxic gait. So those are some prime features you might be using. Then there are certain specific things you will come across in cord syndromes because they affect the spinal cord at different points, right? The different cord syndromes, and I think I'll get to that separately. But you will see that the dorsal column, spinal thalamic tract, corticospinal tract are affected in different ways in different cord syndromes, and that's what affects their presentation. And lastly, if you're looking at spinal cord, you might have to check the levels. So that's basically the neurological examination. I think it's pretty straightforward, but again, know the interpretation. Always keep in mind that you're doing something to identify something, and don't overcomplicate it. It's better to start something, uh, start doing it, and then eventually, you get a hold of how things work out. Because you don't like tell this much detail in the start of. I never was able to tell this much when I was a medical student. If I was, I would have been really easy. So, yeah. So with experience, you learn to add more, and you become better at your examination.